Dear students, welcome back. Now in this session we are going to discuss about the Q angle. Okay, so the net effect of the pull of the quadriceps, okay, as well as the patellar ligament. So if this is the patella, okay, so now this is the patella here, and the net effect of this quadriceps pull and this patellar tendon, that is patellar ligament, is commonly assessed by clinically using the Q angle of the knee or quadriceps angle of the knee. How this Q angle is measured? So the Q angle is the angle formed between a line connecting the anterior superior iliac spine, okay, and to the midpoint of the patella, and a line connecting the tibial tubercle and the midpoint of the patella. So this one is the another one. Okay. So this is called as Q angle. Okay. The Q angle is the angle formed between the line, okay, between the line connecting the anterior superior iliac spine, from the anterior superior iliac spine to the midpoint of the patella, okay, and a line, what is the other line? And a line connecting the tibial tubercle and the midpoint of the patella. If you extend this line, and these two forms an angle here, that is called as Q angle. So an angle of 15 degrees is considered to be normal. Okay, an angle of 15 degrees is considered to be normal. With females, which is having a slightly greater Q angle than males. Why? Because the increased angle among females is due to wider pelvis. This wider pelvis normally in females, it leads to some coxa vara like condition. That means there is an increased femoral anteversion, okay, and which causes a relative knee valgus. Okay, that is the thing in females. In Q angle, the Q angle is usually measured with the knee in extension. Very important thing. So the Q angle is usually measured with the knee in extension. Since excessive lateral forces may be more of problem here, and because as the knee is flexed. So why we are not choosing this value in knee flexion means here there are excessive lateral forces or acting during flexion. Okay, the Q angle will reduce. Here if you see, the Q angle will reduce if tibia rotates medially. That means Q angle is going to reduce if tibia rotates medially. So you can see if tibia is rotating medially, then what happens to this vertical line which is connecting the tibial tuberosity and the Q angle. So this line will comes very much almost nearer to this, the line which is connecting anterior superior iliac spine to the midpoint of the patella. So definitely the angle is going to reduce here. A Q angle of 20 degrees or more, a Q angle of 20 degrees or more is considered to be abnormal. So here this is the condition. So this one is abnormal, creating excessive lateral forces on the patella, creating excessive forces on the patella that may predispose the patella to pathological changes. Although an excessive large Q angle is usually an indicator of some structural malalignment. Okay, an apparently normal Q angle is not necessarily consistent with this absence of problems. So the line between ASIS of the pelvis and the mid patella is only an estimate of the line of pull of quadriceps. If substantial imbalance exists between the vastus medialis and vastus lateralis muscles, the Q angle may underestimate the lateral force on the patella, since the actual pull of the quadriceps muscle is no longer on the estimated line. Okay. So these are the things also we have to consider. This pull is only for good quadricep muscles. Okay. Yes. Next, similarly, a patella that is already subluxed or dislocated may be seen with inaccurately small Q angles, and which is going to be misinterpreted as normal. Okay, so you have to consider that one also. If any small Q angle is there, then we should not said that the patella is in normal, because there may be a small dislocation. So small dislocation or subluxation also shows some small Q angle. Okay, you have to focus on that one also. Okay, forces other than the alignment and balance of the components of quadriceps muscles may influence patellar positioning. Okay, excessive tension in or adaptive shortening of the lateral retinaculum or stretch of the medial retinaculum have been implicated in patellar dysfunction. That means the transverse stabilizers, any excessive tension which is created by lateral or medial, which also show the patellar dysfunction. Excessive tension in the lateral retinaculum. So normally the lateral retinaculum, excessive tension in the lateral retinaculum means there may be weakness on the VMO. Okay, may cause patella to tilt laterally. Okay, thus increasing compression laterally and reducing it medially. There is some indication that the patellar connections to the iliotibial band may exert an excessive lateral pull on the patella when iliotibial band is tight. It is unknown whether changes in the passive structures are primary and or secondary to changes in the dynamic stabilizers. Okay, so any misalignment of the medial lateral stabilizers of the patella may lead excessive pressure on the lateral patellar facet. Okay, even large lateral forces can be prevented from subluxing or dislocating the patella as long as the lateral lip of the femoral sulcus is of sufficient height. Okay. So all these things we have to consider when we check the position of the patella. Okay, so and mainly this Q angle is only for assessing the net effect of the pull of the quadriceps and patellar ligament, which helps in the forces which are acting longitudinally. Okay, so and this is all about the Q angle, and you should also consider the remaining factors which are going to affect Q angle also. Okay, that may be in any concomitant joint positions which also causes changes in Q angle. Okay, all these things we are going to study in the effects of injury and disease, especially in the patellofemoral joint injury. What happens if Q angle is increased and Q angle is decreased? We are going to discuss in that thing. Okay. So thank you. In the next session, we are going to discuss about effects of injury and disease of the entire knee complex. Thank you.